Hello all. So to now we'll be dealing with some of the high-yield MCQs in pharmacology. So we will go with 2 sessions. So today we'll be covering around 65 MCQs and tomorrow also we'll do the same. So come join with me and let us learn this pharmacology together. So now let's start with the very first question. So the first question is, in the dose response graph which is shown below, curve A, it represents the action of acetylcholine alone. And which drug is most likely responsible for producing the A plus C curve? So what do they say? This curve A, it belongs to acetylcholine, and they are asking, what does this curve mean? So what is the meaning of this? Before we want to know about these curves, we need to know the meaning of 2 words, which is called as potency, and the other word is called as efficacy. So what is potency and efficacy? Potency means the dose which is needed to produce a required effect. So if a drug is called as more potent, if it produces a good response at a less dose. Whereas a drug is called as less potent when the same response is produced at a greater dose. Okay, so when you are seeing this dose response curve, what do you see? Which is more potent? Is it either the graph A plus C or A plus B? It is always the graph A plus C which is more potent. What is least potent? Least potent is the one which is A plus B. But what is the meaning of efficacy? Efficacy means the dose which is producing the maximum response. This is called as efficacy. So when seeing this curve, all the drugs are producing the same maximal response. Therefore, all the 3 curves are equally efficacious. That is what we are coming to know from this. But what is our question? We know that A is acetylcholine. We want to know what A plus C is. So what will be the ideal thing? That A plus C should be a drug which is going to potentiate acetylcholine. That is, it is going to help in increasing the acetylcholine concentration. So what should be that drug? That drug should be a acetylcholine esterase inhibitor. So let us see the options and see whether we have any acetylcholine esterase inhibitor here. Yes. So you know the first option they have given is bethanacol. The second option is physostigmine. The third is atropine and the fourth is adrenaline. Among these 4 options, option B is an acetylcholine esterase inhibitor. Therefore, the correct option is option B, which is physostigmine. Why not bethanacol? Bethanacol is a muscarinic receptor agonist. It is not going to potentiate the effect. So, how will the graph look like for bethanacol? It will be the same as like that of acetylcholine itself. Okay. And what about atropine? Atropine is a competitive antagonist of acetylcholine. So if you give a competitive antagonist, in order to increase the effect of acetylcholine, you need to give more dose of acetylcholine. So therefore, the curve A plus B refers to a competitive antagonist, which is atropine. And adrenaline is nowhere related here. It is a sympathetic curve. So what do you mean by this? The curve which is more towards the left-hand side is more potent, whereas the curve which is more towards the right-hand side is least potent. And efficacy is determined by the maximum height of the curve. So this finishes our first question. Now moving into the second question. Match the following drugs and toxins with their specific antidotes. So before knowing this, we will have a look at the list of antidotes which we are going to learn. Okay. So what is the antidote of paracetamol? The antidote of paracetamol is N-acetylcysteine. And if you're going to give anything orally, then it can be methionine. For opioids, it is naloxone. For benzodiazepines, it is going to be flumazenil. For heparin, it is protamine sulfate. And what about for the next drug, which is warfarin? It is vitamin K. Why? Because warfarin is a vitamin K antagonist. Okay, so we are going to give vitamin K itself as an antidote. And what about for dabigatran? It is edaraxizumab. It is a monoclonal antibody, which is very important. Okay, and for factor 10 inhibitors, it is andizanic alpha. How do you remember this? Because this is a factor 10A inhibitor, and this also has 10A within its name. And for OPC poisoning, you know it is going to be atropine. For methanol, it is going to be fomepizole. And for ethylene glycol also, it is going to be fomepizole. For cyanide, it is going to be cyanocobalamin. Okay, so cyanocobalamin, it can be given for cyanide poisoning. Other than that, there are two more drugs which can be given, which is sodium nitrite. And the other drug which can be given is sodium thiosulfate. So all these three drugs are given for cyanide poisoning. I'm going to take a little time in this question because this antidote, it can be asked in two subjects. Either in pharmacology also it can be asked, in forensic also it can be asked. So it is better you know the entire list of antidotes. That is why I'm giving a little more importance to this. And what about for iron? For iron, the antidote is desferrioxide. And for lead, it is disodium EDTA. Disodium EDTA. And for arsenic, it is going to be BAL. And for mercury also, it is BAL. So for these two drugs, it is going to be BAL. And for copper, it is D-penicillamine. And for digoxin, you have a specific thing which is called as digibind. INICET, you're going to give pyridoxine because INICET, it is going to cause peripheral neuropathy. And we are going to treat this by giving pyridoxine. And for methemoglobinemia, you have methylene blue. So you can remember like that. Both starts with meth. Okay. So for methemoglobinemia, it is methylene blue. And for carbon monoxide, it is going to be 100% oxygen, which is otherwise called as hyperbaric oxygen. And what about for beta blockers? For beta blockers, you're going to give glucagon. And for calcium channel blockers, the calcium is blocked. So what are you going to replace it? You're going to give calcium itself. Okay. So you're going to give calcium gluconate. And for TCA, TCA is an acidic drug. So you're going to remove it by the body by giving an sodium bicarbonate. By making the nature alkaline, you're going to excrete the drug out of the body. Therefore, you're going to give sodium bicarbonate. And what about for sulfonylurea-induced hypoglycemia? You're going to give octreotide. And for insulin overdose, of course, it is known, you're going to give glucose. And for local anesthetic toxicity, you're going to give lipid emulsion. So you can remember as L for L, you're going to give lipid emulsion. And for anticholinergic toxicity, that is otherwise called as atropine toxicity, which can also be asked as datura poisoning. In that, what are you going to give? I'm going to give an acetylcholinesterase inhibitor, which is physostigmine. Why physostigmine? Because physostigmine is the one which is going to cross the blood-brain barrier. Neostigmine acts only peripherally. So I'm going to antagonize my CNS effects also. Therefore, I'm going to give physostigmine. And for cholinergic toxicity, we already saw it is atropine. For snake bite, it is very well known. What is it? It is anti-snake venom. And if it is going to be a cobra poisoning or crate poisoning, extra you can give one more drug, which is neostigmine. And for hydrofluoric acid, what are you going to give? For hydrofluoric acid also, you're going to give the same one which you used for calcium channel blockers, which is calcium gluconate. And for thallium, you're going to give Persian blue. Can you tell me where we give methylene blue? Methylene blue is given for methemoglobinemia. And for here, you're going to give Persian blue. And for gold toxicity, also you're going to give BAL. In what other places BAL came in? The BAL also came in two other places, if you note, that is in arsenic poisoning as well as in mercury poisoning. So far we have seen 3 uses of BAL. Now, coming to the next and the last one which we are going to finish. For methotrexate, what are we going to give? For methotrexate, we are going to give folinic acid. Otherwise, it is also called as leucovorin rescue therapy. Okay. For cyclophosphamide-induced hemorrhagic cystitis, you are going to give Mesna. And for cisplatin toxicity, you are going to give amifostin. And for fibrinolytic, you are going to give tranexamic acid. And for excess of magnesium also, you can give calcium gluconate. For excess of potassium, you can use insulin. And be careful when a question is asked about mushroom poisoning. That because they will be either mentioning whether it is an early mushroom poisoning or a late mushroom poisoning. Or sometimes they can ask us hallucinogenic mushroom. Okay, so you need to look at the type of mushroom which they are asking or the species of mushroom which they are mentioning. For example, the early mushroom poisoning, it is caused by a species called INICET or clitocyte species. For this, the antidote is atropine. Okay. Whereas late mushroom poisoning, which is caused by Amantia phalloides, this is going to cause liver toxicity. So you're going to give hepatoprotectants. And the hepatoprotectants which we can use is silibinin or thioptic acid. This is the treatment for late mushroom poisoning. So do not confuse. For early mushroom, it is atropine. And for late mushroom, it is silibinin. For hallucinogenic mushroom poisoning, atropine is contraindicated in hallucinogenic type. So you need to make a note of this also, right? And for botulism and black widow spider bite, you're going to give antitoxin specific to both of this. So this completes our complete list of the antidotes and the drugs. So if you know this, whatever question they ask from you, you can get the right answer. Now we will come back to the question. As I said, we have took a little amount of time over here. Right. So methanol. For methanol, what is it? It is fomepizole. Opioids, what is it? It is naloxone. Benzodiazepines, flumazenil. And arsenic, it is bar. So now clear? So this completes our second question. Now moving to the third question. A patient presents with acute CNS depression and he has ingested sedative and a hypnotic medication. So after that, there's administration of a competitive antagonist which is acting at a GABA-A receptor of the benzodiazepine site, results in rapid improvement in the consciousness. So what are they asking? Here also they're going to ask the drug and the antidote pair. So we need to match which pairs are correctly matched. So we will look at the options one by one. Benzodiazepines and flumazenil, it is correctly matched? Yes, it is right. Atropine and L-carnitine, what is the antidote of atropine? We saw it as an acetylcholinesterase inhibitor, which is physostigmine. So the answer is no. Barbiturates, is it fomepizole? No. Fomepizole is for which poisoning? It is for alcohol, right? And arsenic and desperioxide, is it right? For arsenic, what do we give? Desperioxide is for iron poisoning. So this is also no. So which pair is correctly marked? It is option A, which is benzodiazepines and flumazenil. So now see, when we have a complete list of antidotes in our hands, we'll be able to answer any number of questions related to this, right? So now we'll move on to the next question. So a 42-year-old patient and he is diagnosed with pulmonary TB and he is initiated on a multi-drug regimen. and that is including rifampicin. So, he is counseled regarding the drug interactions, absorption, and resistant patterns. So, what they are asking, which of the statement regarding the rifampicin is incorrect? Okay, so we need to pick up the incorrect option. So, before we are picking the incorrect options, we need to look at some of the important facts about rifampicin. So, how does this rifampicin work? Rifampicin works by inhibiting an enzyme called DNA-dependent RNA polymerase. And when does a resistance to this drug comes? Resistance to drug comes when there is a mutation in the RPOB gene. And remember, this rifampicin is a cytochrome 450 inducer and also a P-glycoprotein inducer. What is P-glycoprotein? P-glycoprotein is an efflux pump. It is going to throw your drug out of the cells. Okay, so it is a pakka inducer. And anything we need to remember about the absorption and metabolism of rifampicin? Of course, absorption, rifampicin needs to be taken in an empty stomach. Why it needs to be taken in an empty stomach? Because food absorbs with the absorption. Therefore, it is always given in empty stomach. And as usual, it undergoes your metabolism in the liver. Right? So these are some of the facts about rifampicin. And since rifampicin is a CYP inducer, what happens when you induce an enzyme? For example, there is a drug A. And this is metabolized by a cytochrome enzyme. And the patient is also giving rifampicin along with it. Now, what happens? Rifampicin induces this enzyme fast. So, this drug A will be thrown out of the body very soon. So, what will happen? The therapeutic effect of drug A will reduce. So, it results in failure of the drug. Similar way, rifampicin can cause failure of many drugs. So that is OCP, oral contraceptives failure can occur. Warfarin failure can occur. And ART levels can decrease. Your HIV drugs can decrease, especially when coming to the protease inhibitors, nevirapine, and the integrase. These are the major ARTs with which it interacts with. And what about the adverse effects which is exhibited by rifampicin? Rifampicin is a hepatotoxic drug. Other than it being hepatotoxic, it also causes one more thing, which is called as orange urine tears, or all your the fluids in the body, it turns orange in color, your tears, sweat, and urine. Okay, and your drug interaction is also one which needs to be remembered. This is the whole thing about rifampicin. Now we will look at the options which is given. It is transported by P-glycoprotein efflux pump. Is it right? Yes, it is correct. Okay, so this option is correct. The resistance occurs due to the mutation in DNA-dependent RNA polymerase, which is RPOB gene. Yes, this is also correct. Concomitant intake with fatty meals enhances its absorption. Is it right? No, because just now we saw it has to be taken in empty stomach, right? And it undergoes enterohepatic recirculation. Yes, it is right. So the correct option is option C. So this is the option which is incorrect. Clear? So now we'll go to the next question. A 24-year-old patient who is with bronchial asthma is on an inhaled beta-2 agonist for a symptomatic relief. So what is here? What is till now what we have understood? He is taking a SABA. Okay, SABA means short-acting beta agonist. And shortly after the administration, what is happening? He is experiencing fine tremors and palpitations. So what is the least likely possibility among these options? What is the least likely ADR which is to occur? That is a question. So now we must understand that what a beta-2 agonist does. So where is the beta-2 receptor present in the body? The beta-2 receptor is present in the blood vessels. It is present in the lungs. It is present in the skeletal muscles. And also it is present in the liver. In the lungs, what it does, it causes bronchodilation. In the skeletal muscle, what it does, it causes tremors. And in the blood vessel, what it does, it causes vasodilation. And since there is a vasodilation, there can be a little amount of reflex tachycardia which can happen. And also, when the beta-2 agonist is given in a large amount, some can spill to the beta-1. And beta-1, since it is present in the heart, that can also cause a little bit of tachycardia because it is going to increase the heart rate. And what does it do with the liver? In the liver, it is going to increase the glucose. So it increases the gluconeogenesis, it increases the glycogenolysis. By doing all this, it is going to increase the glucose in the body. So that is what we have put. It causes tremors because of beta-2 stimulation, tachycardia because of reflex, and peripheral vasodilation, and hyperglycemia. The one thing which we did not see is it causes hypokalemia. Please understand this. So this beta with salbutamol, if a question is being asked in any of the exams, mostly they focus it on the ADRs. So please remember the ADR. It causes hyperglycemia and hypokalemia. That is, your potassium levels are going to fall. Why the potassium levels are going to fall? Because it's going to cause an intracellular potassium shift. That means it moves the potassium from the blood into your cells. And therefore, the blood levels of potassium decreases. Okay. So the reason for hypokalemia is that they stimulate the sodium-potassium ATPase activity and they shift the potassium from the extracellular to the intracellular compartment. So you need to remember there are two beta agonists, SABA and LABA. Under SABA, you have salbutamol. Under LABA, you have salmeterol and also formoterol. Here you also have one more called terbutaline. Okay, so these are SABAs and LABA. SABA is short-acting beta agonist and LABA is long-acting beta agonist. So in our question, which is the least likely? We know it is going to cause skeletal muscle tremors, peripheral vasodilation, and because of that, there is going to be a tachycardia also. And is it going to cause hyperkalemia? No. It is going to cause what? It is going to cause hypokalemia. Okay. So with this, we'll move to the next question, our sixth question. A patient with focal seizures is started on an anti-epileptic drug that increases the GABA level. So this drug is increasing the GABA level. How is it increasing? By selectively inhibiting GAT1. So GAT1 is a transporter, a GABA transporter. By inhibiting this GAT1, it is increasing the GABA levels in the synapse. So they are asking which drug is going to have this mechanism of action. So below this question, I have listed you the complete list of anti-epileptic drugs, the ADR, the mechanism of action. So many of the anti-epileptic drugs, they're concentrating on the mechanism of action and uses. I'm not going to deal with everything one by one. I will tell you how to learn these anti-epileptics, right? So we know anti-epileptics, it always starts with phenytoin. So before going into this table in proper, please understand all the anti-epileptic drugs, it is going to work by any of the 5 mechanisms. So what are these mechanisms? It is either going to decrease your sodium levels in the body. I mean, it is going to inhibit the sodium channels. In other words, it is going to inhibit the sodium channel. Or it can inhibit the calcium channel. Or it can increase your inhibitory neurotransmitter, which is GABA. Or it can decrease your excitatory neurotransmitter, which is glutamate. So while we are dealing with glutamate, it can either antagonize the AMPA receptor or the NMDA receptor, which is the glutamate receptors. Okay, so these are the main mechanisms by which an anti-epileptic is going to act. So how are we going to learn? Please learn that there are around 6 drugs which acts via the proper sodium channels. So what are these drugs? These drugs are nothing: phenytoin, fosphenytoin, which is a prodrug of phenytoin, carbamazepine, oxcarbamazepine. So these two are related, okay? And you have two L's. What are the two L's? You have lamotrigine and lacosamide. All these drugs, it works by one single mechanism, which is it blocks the sodium channels. So now it is easy to know the mechanism. So one thing you have to know the difference, that is lamotrigine, it has two different actions. That is, it not only blocks the sodium channels, it also decreases the glutamate release also. So lamotrigine has a dual mechanism here. So is there any ADR which I need to remember? Of course, I need to remember phenytoin. It is known to cause gingival hyperplasia and hirsutism, which is very important. And remember, fosphenytoin, when given IV, it can cause arrhythmias in some patient, which is very important. And the other important thing you have to remember is oxcarbamazepine. Oxcarbamazepine, it causes SIADH-like effect and hyponatremia. And also, carbamazepine, it can cause SJS. Okay, so these things you need to remember. And when coming to lacosamide, a specific and unique question they can ask about lacosamide is that it enhances it. So if you see this itself will be different. What is it? It enhances the slow sodium channel. Please remember, so far the sodium channels which you see, they all are inactive state. So they will be telling it blocks the inactive state of the sodium channel. But lacosamide is the only drug which enhances the slow sodium channel inactivation. Okay, so keep this in mind. We will deal with what slow sodium channel is and what fast sodium channel is in the next slide. Okay, so far we have seen all this, and now there is going to be a broad spectrum anti-epileptic which we need to deal with, which is valproate. Okay, so valproate is a drug which acts by all the mechanisms, the sodium, calcium, GABA, everything. So it is going to be a broad spectrum anti-epileptic. And the one specific drug which blocks only the calcium channels is ethosuximide, and hence it is given for absent seizures. And then you have zonisamide, benzodiazepines, phenobarbital, your barbiturates and all. And here comes the two more important drugs, which is thiagabin and vigabatrin. What is thiagabin? Thiagabin, it inhibits the GABA reuptake. So you know this is a synapse, and this is a presynaptic nerve terminal, and this is a postsynaptic nerve terminal. And in the synapse, you have the neurotransmitter, which is GABA. When there is more of GABA, the GABA is taken back into the presynaptic nerve terminal with the help of a transporter, and this transporter is called as GAT. So how is thiagabin going to work? Thiagabin is going to inhibit this GAT. So what happens? The synaptic level is going to increase. So this is how thiagabin is going to act. And what about vigabatrin? Vigabatrin, so this neurotransmitter, it gets degraded with the help of an enzyme, which is GABA transaminase. And vigabatrin is going to inhibit this enzyme. Remember, V for V. Vigabatrin is prone to cause visual field defects. Okay, so this one is more important. And there's one more drug, levetiracetam. What does it do? It binds to the synaptic vesicle protein. So you know the neurotransmitters are concentrated in the synapse. So this synaptic vesicle protein, it binds to this and it acts. So this drug is levetiracetam. So now we will move on to what they have asked, which inhibits GAT1. Just now we have saw the drug which inhibits GAT1 is thiagabin. Okay, so with this, our 6th question is over. Now we will move to the next question. Which of the following drug causes modulation of the voltage-gated sodium channels? Now you have to give a little importance. By selective enhancement of slow inactivation. Just now I said all acts on the normally on the fast channels. There's one drug which causes very slow inactivation, which is called as lacosamide. So the correct option here is lacosamide. Just now we saw. So now we need to, I said I will tell about what fast inactivation is and what slow inactivation is, right? So what is fast inactivation? Fast inactivation means it occurs in milliseconds. It occurs very quickly. And what about slow inactivation? It takes minutes to occur. And when does it occur? This fast inactivation, it occurs during every cycle of the action potential. Whereas slow inactivation, it occurs to neurons only which is in prolonged depolarization state. So, therefore, the main target neurons is the normal neurons is also targeted as well as the prolonged depolarization neuron is also targeted here. But in slow inactivation, only hyperactive neurons are only targeted. And what is the example? Your phenytoin, carbamazepine, all these drugs are fast inactivation. The only drug which is slow is lacosamide. Do not forget this. Lacosamide is the only drug which follows slow inactivation. And what is the clinical implication? Since only hyperactive neurons are targeted, the areas are comparatively less in slow inactivation. So what will be the exam keyword you will be getting? Which anti-epileptic blocks the state-dependent sodium channel or use-dependent sodium channel? If you get these kind, it means it is fast inactivation. Please remember. And if you get any word like slow inactivation, then your answer should automatically be lacosamide. Now moving to the next question, choose the correct option from the given choices. So before we are reading the choices, we see what drug they are dealing with. It is phenytoin and fosphenytoin. So now we will deal with some of the phenytoin facts. Okay. So phenytoin, as we saw, what does it do? It is going to inactivate the sodium channels, especially the fast ones, right? And it has a list of areas like it causes gingival hyperplasia, hirsutism, ataxia, and it causes peripheral neuropathy and cerebellar degeneration and also arrhythmias when given via IV, especially when given via fast IV. Okay, so you need to remember the adverse effects of phenytoin. And what about the elimination kinetics of phenytoin? Phenytoin is a drug which undergoes mixed order kinetics. What is mixed order kinetics? That is, the drug, when given in low doses, it follows first order kinetics. Whereas when you increase the dose, it follows zero order kinetics. And hence, the elimination will be slow. And this can result in toxicity. Okay, so since it follows both, it is called as mixed order kinetics. Now, what is the difference between phenytoin and fosphenytoin? The solubility matters. As I said, fosphenytoin is a prodrug of phenytoin. So, both are water soluble, but fosphenytoin is little more water soluble when compared to that of the phenytoin. And therefore, the IV limitation is less with phenytoin, and fosphenytoin can be used for IM use also, whereas this cannot be used. Okay. And what about the infusion rate? Infusion rate, you need to give very slow IV, and here you can give fast IV also. And purple glove syndrome. What is purple glove syndrome? When you administer phenytoin IV, phenytoin is a highly alkaline drug. So if it extravasates outside the blood vessels, it can cause damage there, and it can cause something called as purple glove syndrome. And this is more with phenytoin, which is not seen with fast phenytoin. And cardiovascular toxicity is more with phenytoin, and it is less with fast phenytoin. And this is a prodrug. So this image represents purple glove syndrome, which is caused by phenytoin when it is extravasated outside. Okay. So what are the options which is given here? The maximum oral dose of fosphenytoin, they are asking the correct option here. Okay. So the maximum oral dose of fosphenytoin causes cerebral degeneration and brain atrophy. Yes. Does it cause cardiotoxicity? No. Does it cause nephrotoxicity? No. The only toxicity in high doses it affects the CNS. Okay. So cerebellar degeneration occurs. And the same dose is 250 mg, which is very high. Okay. It is only 15 to 20 mg. It is not 250 mg. So this option is false. And fosphenytoin is given to all seizure patients in the ER, irrespective of the CNS side effect and hypertension. No, it is not given for all seizure patients. It is indicated only in cases of status epilepticus. And also it is given for acute termination of a seizure. These are the only indication fosphenytoin is used. It is not used for all patients. So the right option here we have is option A. Okay. And now we move to the next question, which is question number 9. A 7-year-old child with seizures is started on a drug which increases the inhibitory neurotransmitter by here comes reducing the degradation of a neurotransmitter. So based on the diagram, what is the labeled site at which the drug is acting? So we have A, B, C, D, 4 labeled sites. So first we will mark our known sites. So what is A? A is a presynaptic receptor. I hope many of you will agree with me. A is a presynaptic receptor. And what is C? C is a postsynaptic receptor. And what is D? D seems to be a calcium channel. It is marked over there. And what is B? B is something which is engulfing the neurotransmitter, which is blue in color. So this has to be the enzyme. And what enzyme it is? It is GABA transaminase, which is responsible for the degradation of GABA. Okay. So what is the right option? So we have already marked it over here itself. So what is the right option here? Based on the diagram, the drug primarily acts at what site? It is option B. So the right option is option B here. Okay. Now we will move to the next question. A patient with focal seizures is switched from carbamazepine to oxcarbazepine. Which adverse effect should be monitored more closely? So I said, remember the tabular column which I gave back. Okay. In that, I have quoted, if you have forgotten, I have put the table once again here. If you note, carbamazepine, it causes agranulocytosis. But oxcarbazepine, it causes hyponatremia and SIADH-like effect. Okay, so this is one of the important side effects which you get with oxcarbazepine. Therefore, the right answer here is option B, which is hyponatremia. Okay, so the moral is that please learn the table. Okay, you will get all the mechanism and ADR in that. Right? Fine. So now we'll move to the next question. A 35-year-old patient who undergoes induction of anesthesia with thiopentone. The drug, so what drug? It is thiopentone. The drug produces rapid loss of consciousness within seconds. Okay, that means the drug is acting quick. How quick it is acting? It is acting in seconds. But its clinical effect is short-lived. That means the duration of action is short. So, which of the following statement is incorrect? So, we will see what happens with thiopentone. So, thiopentone, when this is administered IV, the blood concentration, that is the concentration in the blood is going to be high. So, when the blood concentration is going to reduce, it first distributes to brain. So, the brain concentration increases when the blood concentration is reduced. And when it reaches the brain, the patient is going to get anesthetized in seconds. But what did we see? That the duration of action is also short-lived. Why? Because as the brain concentration is reducing, what is happening? The drug is getting redistributed to other tissues. So what is happening? Redistribution is happening. So what is the moral here? That the drug, its action is getting terminated not because of elimination, but it is getting terminated because of redistribution to the other tissues, because it is highly lipid soluble. And this process is called as redistribution. So the short action is not because of excretion, it is because of redistribution. Now we will look at the options. It is a highly lipid soluble drug. Yes. Its duration of action determined by renal elimination? No, just now we saw it is because of redistribution. It undergoes redistribution from brain to muscle and adipose tissue? Yes. And the peak brain concentration is achieved rapidly after? Very true. So which is incorrect here? It is option B. So the right option is option B here. Okay. So now we'll move to the next question, which is question number 12. A critically ill patient is undergoing intubation with an intravenous anesthetic. Subsequently, he develops hypotension and also there is adrenal suppression. So what are they saying? An IV agent is given. After giving an IV agent, the BP is dropping and also the adrenal is also getting suppressed. And they are asking which drug is responsible for this effect. So now we will see about all the 4 drugs which they have asked. So first is propofol. What does propofol do to BP? Propofol is going to decrease the BP. Among these options, there's going to be one more drug which reduces, which is thiopentone. And what is the speciality of propofol? Propofol can also have some amount of anti-emetic action also. And thiopentone, just now we saw it undergoes a process called redistribution. And what about ketamine? Ketamine is called as a dissociative anesthesia, if you remember. And with ketamine, what is happening to the dissociative anesthesia? Okay. And what will be the BP effect of ketamine? It will increase. And what about etomidate? Etomidate doesn't affect BP so much. But what is the one feature about etomidate? It inhibits 11-beta hydroxylase enzyme. That is a special feature with etomidate. So since it inhibits 11-beta hydroxylase, what happens? It is going to inhibit the steroidogenesis and therefore adrenal suppression is going to happen. So now what is the drug which is going to cause this adrenal suppression? It is etomidate. Okay. And one more thing you need to remember about etomidate is that since it does not affect BP so much, it can be given in hemodynamically unstable patient. It can be used. Okay. So please remember this point also when coming to etomidate. Now coming to our next question. A patient on digoxin, he develops toxicity after starting a new antihypertensive drug. So the patient is already on digoxin and now he is starting a new hypertensive drug also. Okay. So now what is happening? This antihypertensive drug is inhibiting a drug reflex transporter. So it is inhibiting a drug reflex transporter, which will possibly be a pre-glycoprotein. So they are asking which of the following drug is most likely for it. That is, which antihypertensive drug has been given, which is going to block P-glycoprotein also. So this can be remembered with the help of a mnemonic. That is, a P-glycoprotein inhibitors list you must know. So what is this list? This list is very angry queen keeps rising concentrations. Okay. So this is the mnemonic you are going to remember for P-glycoproteins. So V stands for verapamil. A stands for amiodarone, Q for curated, K for ketoconazole, R for ritonavir, and C for clarithromycin. So these are the drugs which is going to inhibit the reflex transporter which is P-glycoprotein. And among this, which is a drug which can be given for hypertension? It is verapamil, which is an CCB, a calcium channel blocker. So among this option, which option is right? It is option A, which is verapamil. Clear? Right. So now we'll move to the next question. So, okay. So I would like to touch upon the digoxin toxicity features also. Okay. So digoxin is also a drug which has a very narrow therapeutic index. So digoxin toxicity, even if the serum levels, this you must remember, even if the serum levels are normal, toxicity symptoms can kick in. And the earliest sign of toxicity is GI symptoms. Okay. This is the earliest sign of toxicity, and this can progress to arrhythmias. And the extreme form of toxicity, it affects the vision, especially it affects the color vision, the blue-green one. Okay, so the key point is that even when the therapeutic range is normal, the GI symptoms can be an indicator that the toxicity features are kicking in. So please keep that in mind. And now coming to the next question. A 25-year-old female is brought to the emergency with an injection of amitriptyline. What is amitriptyline? Amitriptyline is a tricyclic antidepressant. She is drowsy and the pupils are dilated and ECG is showing a widened QRS complex. Which of the following finding is least likely in this patient? So, we must understand what a TCA does. What is the mechanism of action of TCAs? So, TCAs are used as an antidepressant. Okay, so depression is a major use of TCAs. And how does it work in depression? That is, it is going to inhibit the reuptake of. It is going to inhibit the reuptake of 5-HT. Okay, not only that, it is going to block histaminic. It is going to block the adrenergic, and also it is going to block the muscarinic receptor also. Because of this blocks this much receptors, all the side effects kick in. Since it blocks the histaminic, drowsiness can occur. Since it acts the muscarinic receptors, anti-muscarinic signs can occur. Okay. In addition, it blocks the sodium channels also, and hence arrhythmias can also kick in. So these are the mechanisms by which a TCA is going to act. That is, it is going to block multiple receptors and hence multiple areas. That is why it is not the first choice in depression, right? So a classical TCA overdose, it has these three signs, that is anticholinergic, CNS toxicity, and cardiotoxicity. So, which is going to happen least likely? Arrhythmias, yes, it can happen. Confusion, yes, it can happen. Mydriasis, also it can happen. Why? When a muscarinic is blocked, what happens? It is going to cause dilation in the pupil. Okay, it can cause muscarinic effects. That is, it can cause dilation. So, what is the only thing which is standing odd one out? It is hypothermia. Okay, because it causes hyperthermia. It doesn't cause hypothermia. So the right answer here is option C, which is hypothermia. Okay, so these are the this is about the TCA and its receptor blockade. Now moving to the next question. A 42-year-old woman, she is getting second-line drug for multi-drug resistant tuberculosis, and she presents with fatigue, weight gain, constipation, and diffuse neck swelling. So with these symptoms, what do you suspect? There is weight gain, there is constipation, and there's going to be a neck swelling. So this indicates that the patient is having signs of hypothyroidism. Okay, so they are asking which TB drug causes hypothyroidism among the options which is given here. So for this, we have to know about the side effects of the drug. What is INI-CET going to cause? Just now we saw INI-CET, it is antidote you are going to give is pyridoxine. Why are you going to give pyridoxine? Because it causes peripheral neuropathy. And therefore, you're going to give pyridoxine. And what about rifampicin? Rifampicin, the main side effect is orange discoloration of urine, sweat, and all. And pyrazinamide, it is going to increase the uric acid levels and cause gout. And all the three are hepatotoxic also. And ethambutol, you know, it is going to affect the eye and it is going to cause optic neuritis. And all the aminoglycosides, which is streptomycin and everything, it is going to cause ototoxicity. Not only ototoxicity, it can cause nephrotoxicity also. So these are the main side effects of the first line drugs. Now, when coming to the second line drugs, you have ethionamide. Ethionamide is a drug which can cause hypothyroidism. Please remember, there is one more drug which can cause hypothyroidism, which is para-aminosalicylic acid. So these two drugs are notorious to cause hypothyroidism. And cycloserine, it is called as psychic serine. So what does it cause? It can cause psychosis. Okay. And amikacin, kanamycin, and capreomycin. This also we just now saw. All the aminoglycoside, it can cause ototoxicity and nephrotoxicity. And linezolid. Linezolid is also a drug which can cause peripheral neuropathy. It can also affect the eye also. Okay. So we have seen two drugs which causes peripheral neuropathy. One is isoniazid and the second drug is linezolid, right? And what about bedaquiline and delamanid? Bedaquiline and delamanid, it can cause QT prolongation. And clofazimine is going to cause skin discoloration, which is the other thing which causes discoloration of your body fluids, that is rifampicin. And clofazimine is going to cause discoloration of the skin. And your fluoroquinolones, which is levofloxacin and moxifloxacin, it is going to affect your tendons. It can cause tendon rupture. It can cause phototoxicity. And pritomanid is a drug which can cause neuropathy and it can also affect your liver. Okay. So our question is, which of the following drugs causes hypothyroidism? So I said there are two drugs which can cause hypothyroidism. One is ethionamide and that second is PAS, which is para-aminosalicylic acid. So among the options which is given, you have ethionamide here. Okay. So the answer is answer B. What about other options? Pyrazinamide, it causes gout. Cycloserine, just now I said it is called as psychic serine. Okay. And streptomycin, it comes under aminoglycosides, it causes ototoxicity and nephrotoxicity. Clear? So this is about the ADR of the important tuberculosis drugs. And now coming to the next question. A hospitalized patient with resistant gram-positive infection is started on an antibiotic that is inhibiting the protein synthesis. Okay, so what is it inhibiting? Protein synthesis in the bacteria, it is inhibiting. How is it inhibiting? By formation of the initiation complex at 50S ribosome. So it is acting on the 50S subunit. So which drug is most likely to be administered? So you need to, you know that the antibacterials can have two mechanisms of action. One is inhibiting the cell wall. The other is inhibiting the protein synthesis. If it is inhibiting the protein synthesis, it can either be acting as a 30S subunit or it can act as the 50S subunit. When it is acting as the 30S subunit, what are the two drugs? What are the two drugs which acts as 40S? A for aminoglycosides and T for tetracycline. Okay, so these are the two drugs, AT30. And CELSET 50. What is CELSET 50? It is chloramphenicol, erythromycin, which is a macrolide. And you have linezolid and streptogramins. all act at your 50. Okay, so you need to remember these two things. So what they have asked, which is acting at 50 years? Just now we saw linezolid is a drug which is going to act at the 50th subunit of the ribosome. So the correct option here is answer C. Now moving to the next question. An 8-year-old girl is on carbamazepine and she is developing diplopia, nystagmus and gait instability 2 days after starting erythromycin. So she is on carbamazepine and then she was given erythromycin. After giving erythromycin, what is happening? She is developing symptoms such as gait instability. Now, what is the cause? So the cause is obvious here. What is happening? There's going to be increase in the level of carbamazepine. Why there is increase in the level of carbamazepine? Because the cytochrome enzyme, which is metabolizing carbamazepine, is inhibited here, which leads to increase in the carbamazepine level. And what is the inhibitor here? It is erythromycin. Okay, so you need to know the list of inducers and the inhibitors. Coming to the list of inducers, so you should either remember the inducers or inhibitors. It is easier to remove the inducers. It is easier to remember the inducers here. Okay, so what are the inducers? It can be remembered with the help of a mnemonic, which is GPRS cell phone. G stands for raciosulfin, P stands for phenytoin, R rifampicin, S smoking, C carbamazepine, and P is for phenobarbital. Remember, all the anti-epileptics are inducers, except one anti-epileptic, which is valproate. And all antibiotics are inhibitors, except two, which is rifampicin and raciosulfin. Okay, so the right answer here is increased carbamazepine levels due to enzyme inhibition. This is the reason why the patient developed gait. And hypersensitivity reaction and breakthrough seizure is not the correct option here. Why? Hypersensitivity reaction, it occurs it presents like SJS, that is Stevens-Johnson syndrome. And also it is not a case of erythromycin toxicity also. And breakthrough seizures means the patient will have seizures as of like the seizure features as such, which is not presented here. So the correct option is option A. Now, match the following. So they have told about tolerance here. So before we are going into the topic, we'll see what is tolerance. Okay. So what is tolerance? What is tachyphylaxis? Tolerance means on repeated dosing of a drug, there will be decrease in the response which is happening. This is called as tolerance. Tolerance is classically exhibited by opioids. What is tachyphylaxis? Tachyphylaxis is acute development of tolerance is called as tachyphylaxis. And the drug which exhibits this is ephedrine. And what is reverse tolerance? Reverse tolerance means there will be an increase in response on repeated dosing. And this is seen by cocaine. And cross tolerance means two drugs. If there is a tolerance to drug A, drug B will also get tolerance even without your giving it. That means all these drugs, it belongs to a same class, or it may act by other same mechanism of action. An example for this is alcohol and benzodiazepines, right? So now let us see. Acute tolerance. What is acute tolerance? Repeated use of a drug in one category confers tolerance to the drugs in the same category. So this one we saw. What is it? This is cross tolerance. Now let us read the next statement. Rapid tolerance developing with repeated use on a single occasion. This is called as acute tolerance. Increase in response on repeating the same dose. This is called as reverse tolerance. I hope now you are clear with that, clear with what tolerance and what tachyphylaxis is, right? Now, so this is what I explained. Tolerance is, as I said, decrease in response, but this occurs on chronically. This is acutely, okay? If it happens acutely, this is called as tachyphylaxis. And the mechanism for tolerance is, it is mainly because of downregulation of receptors. And for tolerance, it is mainly because of neurotransmitter depletion. And if you increase the dose, some amount of response can be seen. Here, no response can be seen. Whereas the recovery is delayed for tolerance, whereas for tachyphylaxis, it can occur soon. And examples just now we saw, for tolerance, it is going to be opioids, and for tachyphylaxis, it is going to be ephedrine. Okay, so this completes our question. Now coming to this next question. What is the function of phase 1 reaction in a xenobiotic? So we need to understand what is the process of metabolism here. So metabolism is a process which is going to convert a lipid-soluble drug into a water-soluble drug. Okay, so this can occur in two phases, which is phase 1 and phase 2. What is the function of phase 1? The function of phase 1 is to introduce functional groups. And under this, you have reactions such as oxidation and reduction and hydrolysis. And the major enzymes which is involved is cytochrome 450 enzymes. And what will be the effect? The effect will be that it is going to make it a little polar. And what about phase 2? Phase 2 is called as conjugation reaction. And under this, what type of reactions comes under? So in this, you have the glucuronide conjugation, glutathione conjugation, sulfate conjugation. All these comes under phase 2. Okay, so these are mainly transferases enzyme which is going to act here. And what is the end effect? It is going to make the compound hydrophilic. That is, it is going to make it water soluble. Okay, so now let us look at the options. So what is the function to make the compound more permeable across the membrane? That means lipid soluble, is it? No. To extract the functional groups? No. It is going to add functional groups. Okay, it is not going to extract the functional groups. And the third is to introduce functional groups. Yes. And to directly conjugate? No. So directly conjugate is phase 2 reaction. It is not a phase 1 reaction. Okay. So now let us move to the next question. A 62-year-old with AKI was admitted with declining urine output. So the intern is giving phenaldopam IV. So they are asking, how does this phenaldopam improve the renal function in this patient? So if you see, phenaldopam, it comes under the roof of exogenous catecholamines, which is directly acting. Among the exogenous group, you have a list of drugs, which is dopamine, phenylephrine, dobutamine, dopexamine, and phenaldopam. Dopamine is a drug which has which acts on 3 receptors. That is, in high dose, it acts on alpha-1 receptor. In moderate dose, it acts on beta-1 receptor. And in low dose, it acts on dopamine receptor. Phenylephrine acts on alpha-1. Dobutamine, it acts on beta-1, and as the name suggests, D1. Dopexamine acts on beta-1, beta-2, as well as D1. Phenaldopam is a drug which doesn't act on any other thing. It acts only on the dopamine agonist. Okay, so this is how phenaldopam is going to act. So what is this phenaldopam going to do? This phenaldopam, by acting as a dopamine agonist, it is going to cause vasodilation of the renal arteries. That is, both the afferent and the efferent arteries. And it is going to increase the GFR. So, phenaldopam among the options, which is it? It doesn't act on alpha-1. It doesn't act on beta-2. It doesn't act on D2 also. It acts only on D1. So, the correct option is dopamine 1 receptor agonism, which is causing dilation of the afferent and efferent arterioles. So, the option here is option A. Now, moving into the next. A doctor wants to calculate the loading dose of a drug that is given orally. The loading dose will be dependent upon which of the following parameters. So what is the formula for calculating the loading dose? Loading dose is equal to target plasma concentration into volume of distribution divided by F, which is bioavailability. This is the formula for loading dose. What is the formula for maintenance dose? Maintenance dose is also the same, which is target plasma concentration. But instead of volume of distribution, what will you get here? Clearance divided by F. So what is the one thing which is changing? Volume loading dose is dependent upon the volume of distribution, whereas the maintenance dose is dependent upon the clearance. Okay. So the loading dose is dependent on which of the following? Yes, bioavailability is needed, BD is needed, target plasma concentration is needed. Which is not needed? Half-life is not needed. So the option is option 1, 2, and 4, which is option A. Now coming to the next question. So, a pharmacist dispenses different drugs under regulatory control as per the Drugs and Cosmetics Act and match the following. So, we need to match which drug falls under which category. So, now we will see what Schedule X stands for. Schedule X stands for psychotropic drugs. Psychotropic drugs means additive drugs. So, it deals with the standards of additive drugs. And what is Schedule G means? Please remember, G is for good doctor. That means what is it? So these drugs should be given only under medical supervision. This is called as Schedule G. What is Schedule H? Just a minute. So what is Schedule H? Schedule H means it can be given. It should be given. H stands for hospital, please remember. That is only under prescription drugs. Only on prescription these drugs should be prescribed. And what does Schedule R stands for? Schedule R stands for the contraceptive standards. So just a minute, I will plug in my charger and I will come back to you. Okay, so Schedule R stands for the contraceptive drug standards. And what does Schedule Y stand for? Schedule Y stands for the, now please note, there is no Schedule Y here. Instead of Schedule Y, it being replaced by the NDCT rules 2019. And Schedule Z stands for the veterinary drugs. It is not the human ones. And remember, Schedule X is different, Category X is different. Category X deals with the teratogenic drugs. Okay, so with this knowledge, we will try to solve this. So what they have given, veterinary drugs. So veterinary drugs, just now we saw it is Schedule Z. So this is done. Then morphine. Morphine we know it comes under the psychotropic category if you remember. So it comes under Schedule X. So 2 is D. So far what have we matched? 2 is D and 3 is C. So the remaining 2 is insulin and hepatitis B. Insulin is a highly dangerous drug. It can cause hypoglycemia. So it should be given under medical supervision. Under medical supervision means under the care of a doctor. So it comes under Schedule G, which is good doctor. Okay. And hepatitis B and comes under, it should be sold under prescription only. So it comes under Schedule H. Okay. So 1 stands for B, 2 stands for D, 3 stands for A, and 4 stands for C. So where do we have this? BDAC, it is option B. So this is the right option. Now coming to the next question. A 52-year-old patient, she has hyperlipidemia with elevated LDL levels and she is on a high dose statin. So the patient is having increased LDL and she started on statin. Now a drug was added which inhibits the ATP citrate lyase. So which of the following statements regarding this drug is right? Okay. So the drug which inhibits this enzyme is nothing but bempedoic acid. It is a new drug. What does bempedoic acid do? We know there is a drug called HMG-CoA reductase. This HMG-CoA reductase, it inhibits the conversion of HMG-CoA to mevalonate. and hence the cholesterol biosynthesis is reduced. Now, this bempedoic acid is going to act further up in the it is going to act further up in the stream. That is, even the conversion of citrate to acetyl-CoA with the help of an enzyme ATP citrate lyase is inhibited by this bempedoic acid. What is the specialty of this drug? This specialty is that it can be given to patients who are resistant to your statins. And another specialty is that this bempedoic acid is a prodrug. Okay, so when you're giving this drug will be converted into active drug only in the liver with the help of an enzyme. So what is happening? That's going to be reduced risk of muscle toxicity. Myalgia will be very less since the active form is formed only in the liver. Even when the blood levels are low, it will not go into the muscles and cause myalgia. So this is the specialty of this drug, bempedoic acid. That is, it doesn't cause muscle toxicity since it is a prodrug. Okay, and it belongs to a family of dicarboxylic acid. Please note this too. So the right option is that it is a dicarboxylic acid inhibitor. It inhibits cholesterol biosynthesis and it is used in statin-resistant dyslipidemia. But note, it is not a non-competitive inhibitor. It is a competitive inhibitor only. Okay, so the wrong option here is this. So this is wrong. So which is the right one? It is 1, 2, and 4. These are the right options. Now moving to the next one. This is also regarding lipids. A 28-year-old man, he also has presenting with elevated LDL levels despite the maximum statin. Now a biological agent is added. The schematic depicts an intracellular. So this biological agent is going to handle the LDL receptor somehow. The drug used, it enhances the receptor recycling and it increases the LDL level. So they are asking what drug it is. So please note, inside the liver, the LDL which is there in the blood will be taken inside with the help of a LDL receptor. Okay, so this LDL receptor will take the LDL into the liver. Okay, and once it takes, it will cause degradation of the LDL and the receptor should come back to the surface for receiving the new LDL molecule. But what happens, most of the times, this LDL receptor will be combined to a compound which is called as PCSK9, which is proprotein subtilin conversion hexane type 9 compound. So when this PCSK9 compound is attached to this receptor, what happens? As usual, the LDL will come and bind to it. It goes into the lysosomes for the degradation. Along with the LDL, the receptor will also get degraded. So what happens? The receptor will not come to the surface and this results in decrease in the LDL receptors. Okay, so now what are we going to give? We are going to give a compound which is going to inhibit this PCSK9. So what compound is going to inhibit this? It is evolocumab, which is a monoclonal antibody. So when this goes and inhibits, what happens? The LDL receptor can freely come to the surface and receive another LDL molecule. So it is this molecule which is causing the degradation of the LDL receptor. Please remember that. And so we need to know about the other two drugs also, which is bempedoic acid. Just now we saw ezetimibe and lomitapide. So what about these drugs? So you know the VDL, LDL, IDL, all these are the major lipoproteins. So this lipoproteins is composed of 4 components, which is triglyceride and cholesterol esters. And surrounding in the surface, they have apoprotein. Okay, so each lipoprotein has a distinct apoprotein, which you must remember. Okay, so these are the list of the lipoprotein you have. Among this, HDL is a good lipoprotein. Okay, and each one has different composition of triglyceride and cholesterol esters. And among this, apoprotein B100 is seen in most of the atherogenic lipoproteins. Okay, understand this. So, understanding this, we will go into another concept because we need to remember about two drugs, that is lomitapide and mipomycin. So to know about that, we need to know the exogenous pathway for lipid metabolism. What is exogenous pathway for lipid metabolism? How the lipids are handled when we are taking it from outside. That is exogenous pathway. So what is happening? There is going to be dietary triglyceride and cholesterol, and it is getting absorbed from the liver. And there is ApoB48, which is an apoprotein. Now, these two needs to be added. Only then it can form what? It can form a lipoprotein. And what helps in adding this triglyceride and cholesterol to this ApoB? It is called as MTP, which is microsomal transfer protein. This microsomal transfer protein is responsible for adding this triglyceride and cholesterol to apoprotein B48, and therefore a lipoprotein which is called as chylomicron is formed. And this chylomicron, it travels across the body, and when it is traveling, it acquires other apoproteins such as ApoC and ApoE from other lipoproteins. Okay, and finally, what happens? There will be lipoprotein lipase which will be activated, and this will get degraded into free fatty acids, and it is taken up by the liver. So what we need to remember here, there is something called as MTP, which is helping in the formation of chylomicrons. Remember this, and we'll keep this aside. Now we will move into something called as HDL, that is reverse cholesterol transport. Reverse cholesterol transport is very important for our lipid maintenance in the body. Here what is happening? Over there what is formed? Chylomicrons is formed. Here what is forming? HDL is forming. How is HDL is forming? HDL is formed the same thing. There is going to be cholesterol. Cholesterol which is taken from the tissues. And in a similar way, there is going to be an apoprotein which is specific for HDL, which is ApoAI. First, ApoAI will be there without any, only ApoAI will be there, and the core compound will be empty. Now, the cholesterol will get transported into the core component. Okay. After getting transferred, what does it form? It forms a HDL. Now, this mature HDL, it can go back to the liver. If it happens, it is okay, well and good for the body. But what happens? Some HDL, it gets activated by an enzyme called CETP, which is called as cholesterol ester transferase protein. What does the CETP do? This CETP, it transfers the cholesterol esters from the HDL to the other atherogenic lipoproteins such as VDL and LDL. So CETP is also something which does bad. So we are going to have two drugs. One is going to inhibit the CETP and the other is going to inhibit the MTP. So what are these drugs? The drugs which is going to inhibit the CETP is called as anacetrapib, and the drug which is going to inhibit the MTP is called as lomitapide. Please remember these two. Other drugs, what we have, CPCSK9 inhibitors, we have already seen. It is MAB, alirocumab and evalocumab. There is one more thing which also decreases the PCSK9 synthesis, which is inclisiran, which is a small interfering RNA. Okay. We also saw as bempedoic acid. And there is something which inhibits the ApoB100 synthesis. We saw ApoB100 is an atherogenic it is an apoprotein which is present in majority of the lipoproteins. So we have mipomycin, which is going to inhibit the ApoB synthesis. And we also have one more drug which is ANGPTL3 inhibitor. This is evinacumab, which is going to increase the LPL activity. Please remember, alirocumab, evalocumab is different. Evinacumab is different. Okay? Right. So, the right answer for this question is, as I said, it is evalocumab. Now moving into the next question. A 25-year patient with glaucoma is treated with a drug which acts at the proximal tubule by inhibiting carbonic anhydrase. Another patient is given a drug which acts as the collecting drug that spares the potassium. So they are asking the site of action of diuretics. So how are we going to remember this? So we will have a look at the nephron here. So the drugs which act on the PCT are carbonic anhydrase inhibitor. Okay. And the drugs which act on the loop of Henle are the loop diuretics. And which acts in the DCT are thiazide diuretics. And which acts in the collecting duct are potassium-sparing diuretics. It also acts in the distal DCT also. And what about osmotic diuretics? The osmotic diuretics, it acts at many places, such as the distal, the PCT, and also the proximal part of the loop of Henle, and many other parts also the osmotic diuretics act. So we will see which of the following statements are right. Osmotic diuretics act in the distal tubule? No. Where does it act? It acts mainly in the proximal convoluted tubule and in the starting part of the loop of Henle. So this is wrong. Thiazides act in the proximal tubule? No. Thiazides act in the DCT. And where does carbonic anhydrase inhibitor act? The carbonic anhydrase inhibitors act in the proximal tubule, which is right. And potassium sparing acts in the collecting duct, it is right. So the correct option is option B, which is C and D. Okay, so as I said, this represents Henle's, which is loop of Henle, which inhibits the sodium-potassium 2-chloride transporter, and the drug which inhibits the sodium chloride transporter in the DCT are the thiazides. And the drugs which acts in the collecting tubule, which spares the potassium, is potassium-sparing diuretic. It can either act as a mineralocorticoid receptor antagonist or it can act as an INICET inhibitor. Okay. And the drug which is going to inhibit the carbonic anhydrase enzyme, it is carbonic anhydrase inhibitors which acts in the PCT. Okay. So these are the site of action of the drugs. Now coming to the next question. A pharmacologist describes that a drug undergoes metabolic activation. That is, let us assume a drug A, it undergoes metabolism to form a reactive intermediate. That means the metabolite is reactive. And this reactive metabolite, it irreversibly inhibits the enzyme that metabolizes them. So what is the meaning? That is drug A, it is getting metabolized. Let's assume some CYP enzyme. Okay, and the metabolite which is formed is also going to inhibit the same enzyme by which it get metabolized into. And this drug is called as an suicide inhibitor. That is, it inhibits its own metabolism. Okay, so this suicide inhibitor, it acts covalently to the same binding site of the enzyme and it inhibits it. So you need to know a list of the suicide inhibitors. So there are a few antimicrobials class which comes under, that is the beta-lactamase inhibitor, that is clavulanic acid, sulbactam and tazobactam. They act as suicide inhibitors. And some anti-Parkinsonism drug, which is MAOA inhibitors, which is selegiline and rasagiline, it also acts as a suicide inhibitor. And N-fluornithin is also a suicide inhibitor, and 5-fluorouracil is also a suicide inhibitor. In addition to these drugs, there are drugs such as ethinyl estradiol, spironolactone, and ritonavir, which can also act as a suicide inhibitor. So among this, which is the only drug which doesn't act, which is benzbromazole. This is a drug which is not a suicide inhibitor. Okay. So now moving into the next question. A 57-year-old man, he develops thrombocytopenia 6 days after the initiation of unfractioned heparin for DVT. So he is given heparin. After giving heparin, after 6 days, what is happening? His platelet is decreased. And what he has been diagnosed with? He's been diagnosed with heparin-induced thrombocytopenia. And he started on an alternative parenteral anticoagulant. During therapy, regular monitoring of APTP is required. Which of the following drug is most likely to be administered? So this is the question. So we need to look at what heparin does. So what is heparin doing? So we know about the coagulation pathway. We know there's something called as intrinsic pathway, and there is something called as extrinsic pathway. So what does this do? Two pathways culminate into these two pathways. It helps in the production of thrombin. This thrombin is called as factor 2A. This is the end point. It helps in the formation of thrombin. What is thrombin going to do? Thrombin is helping in the formation of fibrin from fibrinogen. So this is the mechanism by which thrombin is going to get formed. And what is heparin going to do? Heparin is going to inhibit the formation of thrombin. So we need to look at the list of anticoagulants. So as we already know, the anticoagulants can either be a parenteral anticoagulant or an oral anticoagulant. Under parenteral anticoagulant, we have the heparin, that is low molecular weight heparin, unfractioned heparin, and also fondaparinix. Under direct thrombin inhibitors, you have lepivudin, bivalirudin, and argatroban. You can remember it as BAL. Okay, when coming to oral, in oral, the main thing is warfarin. Okay, and in the oral also, there is a drug which is going to directly inhibit thrombin, which is called as dabigatran. You remember as D for D, which is dabigatran. And other thing are, it inhibits factor 10A. And these drugs have 10A within it. And how does this heparin going to work? This heparin, it is going to form a complex with antithrombin. And this heparin antithrombin complex inhibits two things. What are the two things? It inhibits factor 10A as well as it inhibits factor 2A in the ratio 1:1. The problem doesn't stop with that. It not only inhibits these two factors, it also forms a complex with PF4, which is called as platelet factor 4. When it combines with platelet factor 4, it increases the degradation of platelet. And this is going to result in thrombocytopenia. How are we going to diagnose it? Because the time frame is very important. It usually happens within a week, usually around 4 to 6 days. This thrombocytopenia occurs. If it occurs, we have to diagnose that it is called as HIT, heparin-induced thrombocytopenia. And what is the treatment? The first treatment is stop giving heparin. The second treatment is go for direct thrombin inhibitors. Since it is a parenteral one, go for direct parenteral thrombin inhibitors, which is lepivudin, bivalirudin, or argatroban. Okay, so this is the main thing. This is the main mechanism by which it is acting. That is, it forms a complex with PF4. So now let us look at the options which is given above. Which of the following drug is most likely to be administered? So what should be administered? We should administer a direct parenteral anticoagulant. We should not give heparin derivatives such as a low molecular weight heparin should not be used. Instead, you can go for lepivudin. Remember, instead of lepivudin, if you have two options, lepivudin and bivalirudin, what will you choose? Please choose bivalirudin. Why? Lepivudin is derived from leeches. So there are chances of hypersensitivity reactions which can occur. So keep this in mind. So lepivudin is not a better option. The better option would be bivalirudin. Since that is not available in the options which is given, the correct option would be lepivudin. Now coming to the next question. Which of the following is true regarding the therapeutic index of a drug? So what is the formula used to calculate therapeutic index? Therapeutic index is LD50 by AD50. What is LD50? The dose at which it produces lethality in 50% of the population, and the dose which produces effective dose in 50% of the population is called as therapeutic index. And this therapeutic index is a measure of safety. Please remember. Are there any other measures of safety? Yes. In addition to therapeutic index, you have something called as certainty safety factor. What is certainty safety factor? Certainty safety factor is LD1 by ED99. That is lethal dose, which produces lethality in 1% of the subject, and the dose which produces a good effective dose in 99% of the individuals. So this is much better, or we can call it, it is a much stringent measure of safety when compared to that of therapeutic index. Remember, therapeutic index and therapeutic window are different. What is the difference? Therapeutic index is a number, whereas therapeutic window is a range. What is the range between? It is a range between minimum effective concentration and minimum toxic concentration. The range between these two doses is called as a therapeutic window. Okay. So now let us look at the options. It denotes safety and efficacy? No. It has nothing to do with efficacy. Therapeutic index means it is always safety. Therefore, these two options goes without any asking further questions. And this also, it denotes safety and efficacy? No. So what is the right option here? It is option C. That is the ratio of the medium lethal dose by medium effective dose. So this is the a few examples which I have given here. Like, what is the therapeutic window here? As I said, the difference between these two. So 10 to 20 range microgram per deciliter is the therapeutic window here. And here, what is the therapeutic index from this graph? So if you can see, this is the therapeutic effect, which is achieved at 8. And what is the toxic effect achieved in 50% of the population? It is 128. So this is how you calculate 128 divided by 8. So this gives the therapeutic index. Hope this clears what is therapeutic index, certain safety factor, and therapeutic window. And now coming to the next question. A patient is receiving intravenous vancomycin, which receives dose adjustment using a standard nomogram. Which of the following nomogram is used? First, what is a nomogram? Nomogram is a graphical tool. What is it used for? It is used to calculate either a dose, toxicity, or any physiological value. That is, instead of doing any complex calculations, without doing any complex calculation, we use simple parameters such as the age of the patient, creatinine clearance of the patient, or the dose of the drug which he is receiving, and we plot it into a graph, and then we arrive at a clinical decision. This is how a nomogram is used. So, for different purpose, there are different nomograms. For example, there is a nomogram which is named Roomack-Matthew nomogram. What is Roomack-Matthew nomogram used for? The Roomack-Matthew nomogram is used in case of paracetamol poisoning. It determines the need of N-acetylcysteine. So in Roomack-Matthew, hours post-injection and the serum paracetamol concentration every hour. So we get a slopes like this. So depending upon the slope, we need to dose the NAC. So it helps in dosing the NAC. So Roomack-Matthew is used for paracetamol. Similarly, there is one more nomogram which is called a Salazar nomogram, which is used for creatinine clearance estimation in obese patient. Okay, and there is one more nomogram which is called as Matsky nomogram. This Matsky nomogram is used for determining the vancomycin dosing interval. Okay, so this is the use of Matsky nomogram. So this represents Matsky. Okay, right. Now, Matsky is used for vancomycin. How do I remember this name? Matsky. So here there is a V here, which stands for vancomycin. Remember like that. Gromat. There is a P which is hidden. It is given for paracetamol. And Salazar is used for creatinine clearance, which is used in obese patient. And there is one more nomogram which is called as Haldane or Halstead nomogram. Where it is used in case of carbon monoxide poisoning. And why is it used? It determines the amount of oxygen which is needed to be given. This is Haldane nomogram. So what is our question? The nomogram which is used for intravenous vancomycin, which is nothing but Matsky nomogram. Clear? Now let's move into the next question. Question number 30. A patient presents with bipolar disorder and he is on pharmacotherapy, long-term pharmacotherapy. And now he presents with mild neurological syndrome. Laboratory evaluation shows the drug is within the therapeutic range. Now something should strike a mind. Among the drugs used for mania, which drug it is used for, which drug they usually see the therapeutic range? That means for which drug therapeutic drug monitoring is usually done. So the therapeutic drug monitoring is usually done for, just a minute. So the therapeutic drug monitoring is usually done for just a minute. Okay. So sorry for the interference. We will short startly. Okay. Now we will return. So therapeutic drug monitoring is done for a drug which is called as lithium. So lithium is a drug which is used for acute mania. Okay. So what are the drugs used for mania? The main drugs which is used for mania are lithium, valproate, carbamazepine, and also lamotrigine. And in cases of acute presentation of a mania, we cannot wait to give lithium and for the symptoms to get suppressed. Okay. So in these cases, we can go for benzodiazepines to reduce the sedation and agitation. And also, we can also use atypical antipsychotics, which can be controlled for, which can be given to control the agitation in acute mania. So since they have told about a word called therapeutic range and mild neurological symptoms, what should strike our mind? The drug lithium should strike our mind. Why should it strike our mind? Because the normal therapeutic level of lithium in the body is 0.6 to 1.2. Even with this, even when the lithium levels are normal in the blood, it can cause mild tremors. And when there is a toxicity which is kicking in, and when there is a mild toxicity and the blood level ranges to 1.5 to 2, it can cause post tremors. It can cause ataxia also. And in moderate toxicity, when the range is between 2 to 2.5, it can go for dysarthria. And in severe toxicity, it can go for severe CNS symptoms. Okay, and even can end up in coma also. So this lithium is a heavy toxic drug. So as I said, there was one more drug which was used in heart failure, which is digoxin. So even in digoxin also, I said, even when the serum levels are normal, a mild GI symptom can indicate that the patient is going into toxicity. Similarly, mild tremors are seen even with the therapeutic doses of lithium. Okay, so the CNS adverse effect of lithium is tremors, and the renal side effect of lithium is it causes diabetes insipidus. It can cause hypothyroidism, and in the cardiac, it causes arrhythmias, which is mostly seen in severe doses. Okay, so you can add arrhythmias here. So, in addition to that, it can cause Epstein anomaly in the baby if it is given in pregnancy. So, among the options, what is right? It is indicated for absent seizures? No. What are the drugs indicated for absent seizures? It is valproate and ethosuximide. It is given via oral formulation. It is very well absorbed to the GI tract. So, this is also wrong. It can cause fine levels at therapeutic levels? Yes. So, this is the right option. It is teratogenic. It is not teratogenic. No, it is teratogenic. It causes Epstein's anomaly. Okay. So now moving into the next question, which is question number 31. A 19-year-old woman, she presents with obesity and hyperphagia. Genetic evaluation reveals impaired signaling through this is a keyword, cytokine receptor associated pathway involving intracellular tyrosine kinase. So you need to remember which hormones or which neurotransmitter acts via which receptor. So in this tabular column, I have given the entire list of neurotransmitter. So how do you remember it? So remember there are 4 types of receptors: inotropic, GPCR, protein kinase, and intracellular receptors. Among that, inotropic is a receptor which is fast acting, and intracellular is the one which is slow acting. Okay, so if it is fast acting, most of the neurotransmitters which acts via the CNS, it acts via inotropic, your glutamate, AMPA, GABA, glycine. So this is easier to remember. In addition, you have 2 more, which is nicotinic and 5-HT3. So our inotropic thing is over. Now we will concentrate on the protein kinase receptor. Where is protein kinase? When you hear the name protein, what strikes your mind? Cell division. So the hormones which is responsible for the anabolic effect, which is more involved in cell division, it works via tyrosine kinase receptor, especially your insulin-like growth factor, your GH prolactin, your erythropoietin, thrombopoietin, and cytokines interferons, which is mainly involved in inflammation in the body, and your leptin, which is an satiety hormone. All this acts via protein kinase receptor. And what about GPCR? Rest all acts via GPCR. For example, we saw GH and prolactin here. So except of GH and prolactin, all other pituitary and hypothalamic hormones, it acts via the GPCR. And we saw nicotinic in inotropic, muscarinic comes here, and your adrenergic comes here. We saw 5-HT3 nicotinic in inotropic. Here, 5-HT127 comes here. Other than that, you have dopamine, which is one neurotransmitter which works in the CNS also, but it comes under GPCR. And you have adenosine, chemokine, and cannabinoids. And now coming to the last group, which is intracellular receptor. Please remember, among our sex hormones, estrogen is the only one which acts via the intranuclear. The other thing, that is testosterone, progesterone, acts via the intracytoplasmic. And the other hormones are your glucocorticoids, mineralocorticoids, and vitamin D. So this intranuclear, it can be remembered with the help of a mnemonic called TAPE, which is thyroxine hormones, your vitamin A, PPAR alpha, and your estrogen. Now let us move back to the question. Which of the following acts via tyrosine kinase receptor? So the one which acts via tyrosine kinase receptor is leptin. And what about these two? These two acts via GPCR only. Okay, and aldosterone acts via intracellular receptor. Because just now we saw the diagram of the mineralocorticoid receptor, which the potassium sparing diuretic is going to act. Okay, if you remember the diagram, you can see the mineralocorticoid receptor will be there in the cytoplasm, and once aldosterone comes and act, it moves to the nucleus. Okay, so it comes under mainly intranuclear family. So it comes under the gross classification of intracellular receptors. Now coming to the next question. A child is brought to the emergency with sweating, lacrimation, elevated BP, and painful erection. Examination suggests autonomic overactivity. What is the management? So now we need to differentiate what poisoning it is. Now, what are the symptoms and signs of OPC poisoning? The symptoms and signs can be remembered with the help of a mnemonic called dumbbell. D for diarrhea. U for urination. M for meiosis. B for bradycardia. E for emesis. L for lacrimation. And salivation and sweating. In addition to this, OPC poisoning also has nicotinic symptoms. What are the nicotinic symptoms? It increases the muscle contractions. Okay, and when it goes and stimulates the ganglia, it can increase the BP, but this happens at higher doses only. These are the nicotinic symptoms of the OPC poisoning. Now coming to snake bite. What are the symptoms of snake bite? Especially in neurotoxic snake bite, the symptoms such as ptosis, ophthalmoplegia, dysphagia, and respiratory paralysis occurs. But in case of chemotoxic snake bite, such as viper, your bleeding, hematuria, DIC, shock, and acute kidney injury can happen. None of these features were present, except there was sweating and lacrimation. That is the reason we have to put OPC also under our differential diagnosis. But the other two are very different. That is, the BP is racing, and there is priapism, which is painful erection, which is also happening. So what did we miss out? We missed out another poisoning, which is scorpion sting. So what is the scorpion venom contains? The scorpion venom, it causes increase in the release of catecholamines in the body. In addition to catecholamines, it also stimulates the parasympathetic system also to a smaller extent. So what happens when catecholamines are increased? It causes vasoconstriction. It causes increase in BP. This is the reason the patient is having increase in BP. And why she is having priapism? Because the painful erection is happening because of the acetylcholine. It goes and acts on the blood vessels, and nitric oxide mediated vasodilation is causing, and that is the reason for painful erection. So now what is the drug you need to give for scorpion sting? The drug of choice is prazosin. What is prazosin? Prazosin is a selective alpha-1 blocker. So when it blocks the alpha-1, the vasoconstriction symptoms will subside and BP will also get reduced. We are not going to treat this because if you give an anti-venom for the scorpion sting, that itself will subside the symptoms and no need to use specific cholinergic agent for that. So the drug of choice for scorpion sting is prazosin. So what is the most appropriate management? Prazosin. Do not give epinephrine. What will happen? The vasoconstriction is going to even more increase and it's going to shoot up the BP. So do not give. Anti-snake venom also no, because it's not a case of snake bite, and phytostrigmin also no. Okay? Because it is not an atopin poisoning. Now coming into the next question. Variation in the sensitivity of a response to different doses of a drug. So there is dose and there is response. It is obtained from what? So as you can see, it is already there in the answer, which is dose response curve. The right option here is dose response curve. Therapeutic index, we already saw. What is it? It is LD50 by ED50. And what is bioavailability? Bioavailability is noted by F. And what is it? It is the amount of drug which is reaching the systemic circulation in unchanged form is called as bioavailability. And this has nothing to do with the response and the dose. And phase 1 clinical trials, it is unrelated to the question. So this is what they are. They have telling, that dose and percentage of response which is achieved in different population. This is the curve which they are referring to. Okay, so this is dose response curve. And this is for population dose response curve. There is something we can derive it for each individual also. So if we plot it for each individual, what comes in the y-axis? The same dose comes in the x-axis, but in the y-axis, the effect of the drug comes. So what is this used for? This is used for calculating the efficacy and potency. Not only efficacy and potency, it can also be used to calculate ED50 and LD50 also. And also the therapeutic window and therapeutic index of the drug can also be calculated. Okay, so this is about the dose response curve. So what is the answer here? It is option A, which is dose response curve. Now coming to the next question. A drug with high plasma protein binding is administered. Which of the following PK characteristics is most likely associated with this drug? So now what is protein binding? That is, if you give a drug orally or by IV, it undergoes absorption. And once it undergoes absorption, it reaches your blood. From the blood, it can travel to your organs, or it can stay in the blood and it can combine with your plasma proteins. Your acidic drugs, it binds to albumin. Your basic drug binds to alpha-1 glycoprotein. Okay, so this is the dictum. So what happens if a drug is bound to the plasma protein? It means that it will not reach the organs. That means the volume of distribution of the drug will be very low. When the volume of distribution of the drug is very low, what happens? It gets confined into the blood alone. Okay, and one more dangerous thing is, so plasma protein binding, it decreases the volume of distribution of a drug. The next thing is, when it is bound to the plasma protein, the molecular weight of the drug increases. Therefore, it will not undergo glomerular filtration. And these drugs, it cannot be eliminated quickly by dialysis. Okay, so these are the main things. And the third thing is that it undergoes a process which is called as displacement reaction. What is displacement reactions? For example, there are two drugs. Imagine there is a plasma protein here and there is a drug which is given in blue, which is the drug A. Now, this drug A has a very good affinity for the plasma protein. So it is binding here. Now we are administering another drug, which is drug B. So what is this second drug going to do? This second drug also has the same affinity as drug A. So it pushes the drug A from the side and this goes and attaches. So what is happening? The serum levels of drug A will increase and this will cause toxicity. So plasma protein binding causes displacement reactions. These are the dangerous consequences of plasma protein binding. So now we will look at the options. Which is most likely associated with plasma protein binding? Increases glomerular filtration? No. Why? The weight is increased. So glomerular filtration is reduced. Reduced drug interactions? No. It undergoes displacement reactions. It can displace drugs between the plasma proteins, which can lead to increase in the concentration of either one of the drug. And what about the volume of distribution? It will be low. It is not increased. And reduced renal elimination by filtration. Yes. So the right option is option D. That is reduced renal elimination by filtration. Now coming into the next question. Low apparent, low VD means what? What does low VD indicate? Just now we have seen. What does low VD indicate? That means the drug is not extensively, it is a very direct question. Just now we saw. It means the drug is not extensively distributed in the organs and the tissues. That is the meaning of low VD. See, VD has nothing to do with bioavailability or efficacy or T-buff, right? So the other options are wrong. Now coming to the next question. A drug is administered as a loading dose. Which of the following is not required for the calculation of loading dose? Just now we saw another question with loading dose. What is loading dose? How do we calculate? It is calculated by target plasma concentration into volume of distribution divided by F. So is that here volume of distribution is there? Bioavailability is there. So please remember, this is one point where sometimes a question can be twisted. In the previously asked question, we picked half-life as the answer for the parameter not required to calculate. Here there are two options. One is half-life and the other is clearance. Among these two, if I want to pick one option, which will I pick? I will definitely go for clearance. Why? Because clearance is the one factor which is going to distinguish between a loading dose and a maintenance dose. Okay, so if I want to select one option, my option will be clearance. If I can select two, it can be a half-life also. Okay, so this can have two options, which is clearance as well as half-life. If they are asking one option only, go for clearance alone. Now coming to the next thing. A patient with glaucoma is treated with a drug that inhibits carbonic anhydrase by a non-competitive mechanism. Which of the following changes in the enzyme kinetics is expected? So you need to know what is competitive inhibitor, what is a non-competitive inhibitor, and what is uncompetitive inhibitor. So what is happening in a competitive inhibitor? So in competitive inhibitor, both the substrate as well as the inhibitor, they fight for the same common site. And what about non-competitive inhibitor? In non-competitive inhibitor, both the substrate and the enzyme, they compete for different sites. So there is no competition here. They act as different sites and the end result will be decreased. Okay, and what is uncompetitive? Uncompetitive is totally different. And uncompetitive, the inhibitor cannot bind to the enzyme alone. The inhibitor can bind only when the enzyme is combined with the substrate. Only then it can bind. Okay, so this is the major difference. So what happens in competitive inhibition? In competitive inhibition, if you increase the dose of the drug, the same response can be achieved. Whereas in non-competitive inhibition, even if you increase the dose of the drug, the same maximal effect cannot be increased. So keep this in mind. With this basics, we will move into what is Km and Vmax is. What is Km? Km denotes the affinity between the enzyme and substrate. Vmax, remember, it is a maximal effect which can be seen. What happens in competitive inhibition? In competitive inhibition, we saw if we increase the dose, if we increase the affinity by increasing the dose, what happens? Vmax will remain the same, right? That is the reason in this, Km is increased and Vmax is unaffected. And what happens in non-competitive inhibition? In non-competitive inhibition, both the enzyme and substrate have a different binding site. So the affinity is unaffected here. That is why the Km is unaffected. And why is Vmax reduced? How much ever you increase the dose, you will not be able to see a maximal effect. That is why the Vmax is reduced. And what happens in uncompetitive inhibition? In uncompetitive inhibition, the inhibitor binds only to the enzyme substrate complex. With enzyme alone, it cannot bind. That means the affinity to the enzyme is decreased. That is why Km is reduced. And what about Vmax? Vmax will also be reduced. So this is how the Km and Vmax are affected in all the three kinds of inhibition. If they are showing the graph alone, please remember, if both the lines meet at y-axis, it is competitive inhibition. If both the lines meet at x-axis, it is non-competitive inhibition. If it does not meet at all, it is uncompetitive inhibition. Okay. So now what is the right answer here? It is a non-competitive mechanism. So in a non-competitive mechanism, the Vmax is decreased. And what about Km? The Km is unaffected. Okay. So since Km is unaffected is not the option here, we go only for the option which is decrease in the Vmax. Now moving into the next question. A drug follows first order elimination kinetics. What is the expected effect of doubling the administered dose? So what will happen if you double the dose? That is what we are asking. So in first order kinetics, what is happening? A constant fraction of a drug is eliminated. For example, in 1 hour, if 50% is getting eliminated, in every hour, the same 50% will get eliminated. So imagine you have 100 mg of the drug and 50% is get eliminated in 1 hour. So how many hours is it taking to become a 3.125? It is 1, 2, 3, 4, and 5. So it is taking 5 hours for the drug to get eliminated. Now, what happens if I double the dose of the drug? If I give, so for 100 mg, 5 hours it is taking to get excreted. If I give 200 mg, what happens? 50% in 1 hour. That is a concept, right? So 200 divided to 50% of 200 is 100 mg. And for this, how many hours? 1 hour. And again, the same 5 hours it is going to take to get eliminated. So how many hours is increased? 1 hour is increased. Since it is 50%, what is half-life? Half-life is defined as a time taken for the plasma concentration to reduce to half of the value. Here also the same half value is happening. So what is happening? The T-half is not getting changed. Even for getting 200 to 100, it happens same 1 hour. 100 to 50, same 1 hour. So the T-half is unchanged in the first order kinetics. What happens in zero order kinetics? In zero order kinetics, a constant amount of drug will get eliminated in a unit time. So if you look at this, let us assume we are giving 100 microgram of a drug. And here the amount, let us assuming is 25 microgram. So every hour, only 25 microgram of drug will be eliminated. So for this 100 microgram to become into 25 microgram, how many hours is it taking? It is taking a total of 3 hours. Now, what will happen if I double the dose in this condition? This 200 again has to go to 3 hours to become into 100 mg and 100 microgram. And this 100 microgram again has to go 3 hours to become into 25 microgram. So how many hours is increased? 6 hours is increased. And what about the half-life? What is the half-life in the first condition? 100 to 50. 2 hours is the half-life here. And what is the half-life here? 200 to 100. So how many hours? It is 3 hours here. So what is happening? The half-life is changing and the drug is going to stay in the body for a longer period of time and which is going to become toxic. So this is the main difference between first order and zero order kinetics. So this table demonstrates the major difference. And now when we're looking at the options here, what is the expected effect of doubling? Plasma concentration doubles with unchanged half-life. Very true. In first order, half-life is unchanged, but the plasma concentration is doubled. Both the plasma concentration and half-life doubles. No, the half-life doesn't double, it stays constant. No change? No. Half-life doubles without change? No. So the right option here is option A. Okay. Now moving into the next question. A patient was given digoxin and he started having side effects like nausea and vomiting. We have heard somewhere. The early signs of toxicity is GI symptoms. Now can you correlate? Okay. And the concentration was 4 nanogram per ml. Okay. So the serum concentration is how much? It is 4 nanogram per ml. And the therapeutic range they have given, what is it? It is 1 nanogram per ml. And digoxin half-life is what? It is 40 hours. So what they are asking is, what time is required till you can start digoxin safely? So as you can see, the initial concentration is 4 nanogram. The safety therapeutic level is 1 nanogram. and the half-life is 40 hours, right? That means for becoming 4 nanogram to 2 nanogram, it takes how many half-life? 1 half-life. What is 1 half-life? 40 hours. But what is our therapeutic level? 1 nanogram. So this 2 divided by 2, half of it is 1 nanogram. Again, how much hours will it take? It will take same 40 hours. So to bring it to 1 nanogram, how many hours in total it is taking? It is taking 80 hours. So the answer here is 80 hours. Okay. So only after 80 hours, we can start the next decoction so that it falls within our plasma concentration. Now let us move into the next question. A new drug undergoes sequential evaluation in humans to assess the safety, efficacy, and long-term outcomes. Which of the following statement about these phases is correct? So this question is about the clinical trials. So what is clinical trials? The clinical trials consist of 4 phases: phase 1, phase 2, phase 3, and phase 4. In addition, there is another phase which is called as phase 0. This phase 0 is called as microdosing study. And what is the main aim of this? It is to know the PK of a drug. Microdosing study is done. In this, a human equivalent dose, 1/100th of this dose, is usually used. Okay, 1/100th of the human equivalent dose is used. That is very small dose. It is used to know how a drug is absorbed, distributed, metabolized in the body. This is the aim of microdosing studies, and it is done in healthy volunteers in around 10 to 15 patients. Now coming into phase 1. The main aim of phase 1 is to determine the safety. Always we see the safety first, okay? And this is called as FIH, which is called as first in human studies. In this also healthy volunteers are included, and the range of persons who are included in this study will be in tens, that is 20 to 80. Just a moment. Now we will go into the next phase, which is called as phase 2. So what is happening in phase 2? Phase 2 is mainly for checking the safety. In addition to safety, they see the efficacy also. And this is called as therapeutic exploratory study. This is also called as dose ranging study. Okay. So efficacy and dose ranging is seen in phase 2. So it is only during phase 2 the deceased patients are involved. And in this, the sample size will be in hundreds. Okay. In phase 3, what are they doing? Whatever they did in phase 1 and phase 2, they will confirm in phase 3. And that is why it is called as therapeutic confirmatory study. And in this, what will be the sample size? It will be in thousands, 3,000 or 3,000 plus. And the last is called as phase 4. Phase 4 is one where the drug enters the market. So it is called as post-marketing surveillance. And here all the general population are involved, and it will go up to millions and billions. And this is called as pharmacovigilance studies. Okay. So now what are they telling about the clinical trial? Early human. So they are asking which is incorrect. Okay. So please remember that. Early human exposure study may assess pharmacokinetics. Yes, true. Therapeutic exploratory studies evaluate the efficacy. Very true. Large-scale studies compare with the standard treatment. Yes, always if there is a drug which is entering a market, it is usually compared with the standard drug which is already available. That is how the large-scale studies are planned. And confirmatory trials involve a small number. No, confirmatory trial means what phase it is? It is phase 3 if you remember. So it is phase 3 and it involves about 3,000 plus participants. It is not a small number. So the incorrect option is option D. Okay. Now moving into the next question. A drug undergoes enzymatic conversion to form a reactive intermediate that irreversibly inactivates the same enzyme responsible for its metabolism. We saw this already somewhere. What is it? It is called as a suicide inhibitor. This drug is called as a suicide inhibitor. We have already seen what a suicide inhibitor is. So now let us look at the options. Formation of a reactive metabolite. Yes, suicide inhibitor means it forms a reactive metabolite. And covalent binding to the enzyme. Yes. Interaction at the catalytic site or active site of the enzyme. Yes, it binds to the active site. Binding to a site different from a catalytic site. No. This is not the thing. Then what will be this option for? Binding to a site different from the catalytic site means it is a non-competitive inhibitor. It is an active site. It binds to the active site only. Okay. So this is a definition for the suicide inhibitor or suicide drug. Now let us move to the next one. A national health authority is reviewing drugs for inclusion in the essential medicine list to optimize the population level healthcare. So we are dealing with essential medicines here. So they are asking which of the following characteristics would not favor inclusion of a drug in the list. So what is the WHO criteria for essential medicine? What is the essential medicine first? Essential medicine are a group of drugs which satisfy the healthcare need of a population. If it's going to satisfy a healthcare need of a population, it should be given for a disease which is most common. And also, it has to be efficacious. It has to be safety also. The safety profile also matters. And most importantly, it has to be cost effective. And importantly, no FDCs. What is FDC? FDC is fixed drug combination. Why FDCs are not preferred? Because FDCs contain a combination of two drugs. So FDCs have increased propensity to cause ADR, as well as the cost of the drug also increases. Therefore, FDCs are not included under essential medicines except for a few FDCs. What are those FDCs which are included? Your anti-TB drugs, which is available as FDC under essential medicine, anti-HIV drugs, and anti-malarial drugs. Only these three are available as FDCs. Otherwise, essential medicine means it doesn't promote FDCs. Okay. So, what will not be a? They are asking which characteristics would not favor inclusion. Okay. Demonstrate clinical efficacy. Yes, it should be clinically efficient, and it should prioritize a public health condition. It should have a cost-benefit ratio. Preference for fixed drug? No. Okay. So, FDCs should not be an essential medicine. So, this is the answer, option number D. Now, moving into the next question. A commonly prescribed medication carries a label advising store in a cool place. So, drug storage conditions are mostly asked. So, what is store in a cool place means? So, store in a cool place means 8 to 15 degrees. And store at room temperature means it will be from 25 to 30 degrees. And store in a cold place. Please remember, cool place is different and a cold place is different. Cold means it can range from 2 to 8 degrees. And deep freeze means when it is in minus, that is less than 15 degrees, it can be less than, sorry, minus 15, okay? It can be deep freeze. So, store in a cool place means what is the degree? It is 8 to 15 degrees. So, you must remember all these degrees for the drug storage condition. Now, moving into the next thing. A newly graduated intern is writing a prescription adhering to the standard guidelines. So, which of the following prescription is most appropriate? So, please remember, a prescription is something which should be legible and it should contain no abbreviations. So, among the options, you can easily pick up which doesn't contain any abbreviation. It is option A. Okay, because they have it's not written as OD, it is written as once daily, okay, at bedtime. So everything is written very clearly here. So the correct answer is option A. In all others, abbreviations are being used. So this is not the answer. So it's a very simple and direct question which they have asked. Now coming to the next one. A drug is labeled to contain a specific quantity of active ingredient, but on lab analysis, what they have found? It is found it is having a lower amount of the active compound. The problem is that this drug is having low amount of, in other words, please carefully listen, low quantity of active compound. So this comes under what? Counterfeit, spurious, adulterated, or unethical drug. So now let us see what is a counterfeit and spurious is. Counterfeit means it is deliberately made, or it is deliberately made as a fraudulent product, and it may imitate a brand drug. Mostly, there will be a decrease in the quantity of the active ingredient in counterfeit drug. What is spurious drug? Spurious drug means it is an imitation or a substitute product. That is, it is manufactured from under another drug name. That is called a spurious drug. What is misbranded drug? Misbranded means it will have a false claim or it will have a misleading labeling. That is called as misbranded. And what is adulterated? Adulterated means it is always contaminated. This has more to do with the quality of the drug. Okay? Wrong strength or reduced activity comes under what? It comes under counterfeit drug. Okay? So adulterated means reduction in the quality of the drug. So since it is lower amount, what is the correct answer here? It is counterfeit drug. Okay, right. Now moving on to the next question. A formulation is designed to resist disintegration in the acidic environment and release the content in the intestine, which means what is this drug? This is an enteric-coated drug. So which is not the advantage of this formulation? Please remember, when a tablet is enteric-coated, it means that the T-half is unchanged. The only reason is to get a targeted delivery to the intestine. And the other reason for producing an enteric-coated is to protect from the acidic pH of the stomach. Okay, so this is the main reason we are using enteric-coated. So as you can see, enteric-coated means it is a delayed release tablet. It bypasses the stomach. It has nothing to do with the T-half. Whereas sustained release means it is a slow release and it is going to prolong the action and it may prolong the duration. Sustained means it is releasing slow. Hence the duration of action will prolong. Please note, T-half has also nothing to do with sustained release. The duration of action might prolong with this. Okay. So the option here is, which of the following is not an advantage of enteric-coated? Which is not an advantage? Protection of acid-labeled drugs and reduction of gastric irritation, targeted delivery are all advantages. The only non-advantage which is quoted is prolongation of the drug's elimination half-life. Okay, this has nothing to do with enteric-coated formulation. Now coming to the next question. A 24-year-old man is brought to the emergency with GTCS, generalized tonic-clonic seizures, and he is given intravenous lorazepam, which is the drug of choice for status epilepticus. They are asking which of the following does not have a role in the management of status epilepticus. So we need to look at the management of status epilepticus. So what is the first drug we give? As we said before, it is lorazepam, which is the drug of choice. So for status epilepticus, the first drug we start is lorazepam. If the patient is not controlled with lorazepam, we go for fosphenytoin, or we can go for a broad spectrum, which is valproate, or we can go for levetiracetam. And if the patient is not responding to even this, then you can anesthetize the patient. Okay, so this is what we are going to give. So for anesthetizing, you can go for propofol or any other anesthetic agents. So Among this, which of the drug is not given for status epilepticus? As I said, fosphenytoin, valproate, and levetiracetam are given. Among the option, ethosuximide is a drug which is not given. Where is ethosuximide used? Ethosuximide is used for absence seizures. How does it work? It inhibits the calcium channels. Which calcium channels? The T-type calcium channels. Okay, so this is the answer. Now going to the 50th question. A 32-year-old man is treated with haloperidol and he presents with rigidity, hyperthermia, and autonomic instability, elevated CPK, and altered mental status. So which of the following is appropriate for this condition? So what does this mean? Haloperidol is an antipsychotic drug. It belongs to first generation or traditional antipsychotics. Okay. So what is it causing? This is causing something called as NMS. NMS means neuroleptic malignant syndrome. So this NMS, the trigger is antipsychotic drug. Why is NMS caused? Because of the blockade of the dopamine receptors by the antipsychotic. And the onset is, it takes days to occur. And how are we going to treat this NMS? We are going to stop the drug. We are going to stop the anti-epileptic. That is the first thing we do. And the second thing we do is we give something called as dantrolene. We will see what dantrolene is. So we need to learn about malignant hyperthermia as well. What is malignant hyperthermia? Malignant hyperthermia means, you know, this calcium, it is released from the ryanodine receptors, ryanodine calcium release channel. The calcium is released, and this calcium, it acts with the actin and the myosin, and this produces contraction of a muscle. So in some individuals, this ryanodine receptor will be mutated. If it is mutated, it results in continuous release of the calcium. So there will be more calcium which is released, and hence more contraction which is occurring, which will lead to hyperthermia. And this trigger for ryanodine receptor being stimulated is succinylcholine or some of the anesthetics. It can trigger this ryanodine receptor to increase a lot of calcium. So this malignant hyperthermia, the trigger is mainly succinylcholine or a few anesthetics such as halothane or other fluorinated anesthetics like isoflurane or sevoflurane. And the mechanism is because of the mutated ryanodine receptor. And the onset is quick. It occurs very quickly. And for the treatment is giving dantrolene. What does dantrolene do? Dantrolene is going to inhibit this ryanodine receptor, and hence the calcium release is going to get inhibited. So dantrolene forms the drug of choice for two conditions, which is neuroleptic malignant syndrome and malignant hyperthermia. So how are we going to treat the neuroleptic malignant syndrome here? We are going to stop haloperidol and give dantrolene. So the correct option is stop haloperidol and give dantrolene. And now going into the next question, a 45-year-old man with AIDS-related cachexia is prescribed dronabinol for appetite stimulation. Which of the following is false? So first we want to know what dronabinol is. Dronabinol, it comes under the class of tetrahydrocannabinol family. And how does it act? It acts as CB1 and CB2 receptor agonist. And how does it get metabolized into? Same way it undergoes metabolism by the liver, by the CYP enzymes. Okay. And the uses are dronabinol is used in AIDS cachexia. It is also used in CINV. What is CINV? Chemotherapy-induced nausea and vomiting. And it is also used as an antiemetic in other conditions also. And also it finds its way in epilepsy also. So now we will look at what are the statements they have given about dronabinol. It acts via cannabinoid receptor. Yes. So this is true. It is used in pain management. Yes, it is true. It is largely excreted unchanged in the feces. No, it undergoes a proper metabolism and the metabolites get excreted in the feces. So this is the wrong option. And it is used in AIDS-related anorexia and weight loss. Yes. So this is also 2. Okay. So this completes the next question, which is related to cannabinoid. Now we will move into the next question. A trauma patient is requiring ketamine anesthesia. Which of the following is not considered as a recognized advantage of ketamine? So now we will know about what ketamine is used for and what is the relationship between ketamine and opioids. So ketamine is an NMDA receptor antagonist. Okay, so this is the mechanism by which it is going to work. So when the ketamine and opioids are given, the dose of opioids, it can be reduced. Okay, so it helps in reducing the dose of opioids when ketamine is given together. And ketamine is preferred in what patient? Ketamine, it can be given in patients of hemodynamic instability. Okay. So now let us look at the options which are given above. So ketamine, yeah, we know it produces dissociative anesthesia. It is used in hemodynamically unstable patient. Yes. It potentiates the analgesic action. Yes. That is why we can reduce the dose of opioids in this patient. Completely prevalence opioid tolerance? No. It has nothing to do with the prevention of opioid tolerance. The only way is it is going to decrease the dose. Okay. So with this, we are finishing our first part. So tomorrow we will continue with the second part of our high-yield MCQs.